Welcome to In the ED Now, a podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Rebecca Griffith, the ED DPT. And today we have with us Dr. Stephen Goosetree. Welcome to the show.
Hey, Rebecca. Yeah, thanks for having me.
Well, I'm so happy to have you here today because you and I connected through AONT and talking about manual therapy, kind of in general, inside of the emergency department, in outpatient clinics, wherever it might be. And you have a really interesting background. Can you share that with people?
Yeah, absolutely. How much time do you have? Well, started as a PT assistant. That's what, went to undergrad, got the kinesiology degree, and wanted to either be a PT or a PA. That was my dream. Just a little background, my family, my grandpa was a hospitalist, and then he became a urologist. My grandma was his nurse. My mom was a nurse, and my dad was a firefighter paramedic. So kind of a cute story there. My mom was an ED nurse, and my dad was a paramedic, and she thought he was good with the pediatric patients, so here I am.
I love that. That's awesome.
So then worked for a couple of years as a PTA at the Rehab Institute of Chicago, born and raised Chicagoland guy here. So they're like, dude, you either need to go back for your DPT or you need to, become a PA. Like your career ceiling has reached its top in about 2 years. I was maxed out, right? So I don't think they're doing it anymore, but it was a transitional program at Franklin Pierce University out in New Hampshire. So Josh Cleland was my MSK there, research and he had a manipulation elective. So I really, started fanboying for Josh's curriculum. So that was fun. And then, worked in a variety of settings. Ideally, I wanted to do an ortho residency, but after about 2 years, I asked Josh, he's like, dude, just go to UIC's fellowship headed by Carol Courtney. So sure enough, did that and worked in home health, acute care while I was at RIC, you name it. Most recently, I've been at a couple digital startups, and finally, shameless plug, just launched Goosetree Physios. So I have a hybrid practice now, seeing some telehealth, some in person if you're in Chicago. So that's me in a nutshell.
That's awesome. So tell me, you had a little bit of experience in the emergency department, yeah? In the midst of all that?
Yeah, I did. So it was in suburban Chicago at Alexian Brothers. I think it's a level 2 trauma center, but pretty well-known hospital. That's where I was born. So kind of nostalgic there. So I was part of, this was like right out of PT school too. So all the Goodman and Snyder differential diagnoses were still in my brain. Vestibular stuff was still in my head. And of course, manual therapy always. So they reached out to me, my former coworkers, and said, hey, Steve, we would, now that you're a PT, because PTAs, they couldn't diagnose or anything. They were like, Steve, I think you should join this pilot with us and just see how things go. It's going to be brand new. And I get bored easy, Rebecca. So I like being
like that myself.
Yeah. So I like the fast pace, the idea of the ER. I'm like, man, this would be so cool. So me and 2 or 3 other PTs kind of started working in there, and I was just doing that PRN. I think I went in like Tuesday, Thursdays for a couple hours to start with, while I was still doing your PT mill, like kind of entry level, new grad type stuff. And I didn't really tell anybody I was doing that on the side because I'm like, this can either go awesome or this could be a huge flop. And it turned out to be awesome.
I love that. So one of the things I wanted to talk to you about was clinical reasoning. And because you have this really big, diverse background of places you've practiced and how you've practiced, let's talk a little bit about clinical reasoning in the emergency department and beyond. Like, what are your best tips for people about that?
Yeah, that's a great point. And shout out to Carol Courtney and her team for the fellowship. It was just as much a clinical reasoning fellowship and pain science fellowship as it was the actual thrust manipulation or handling skills. So yeah, in the back of your mind, you should always have, not thinking scary pathoanatomy, because we know MSK, there's visceral referral patterns and stuff, but have at least, especially like the low back, I like the spine. So is it maybe a disc, maybe a irritable facet joint, but then always have 1 or 2 zebras in the back of your head too. I think that's a good way to approach, even if it seems super straightforward. You got to assess, don't guess, I guess is a good way to frame that.
Yeah, I think in the emergency department, I usually tell people, like, what's the absolute worst thing it could be? And let's rule that out first, and then we can proceed. And I think the other thing that's helpful too, kind of like you alluded to, is prevalence, right? And understanding the prevalence of different diagnostic criteria, because we do have those zebras that we want to be careful of, especially in the emergency department, because we don't want to miss things. But from a prevalence perspective, which is more likely to be the case?
Right. Usually the MSK at the end of the day.
Yeah.
And when you know, I like to say your PT, spidey senses, you just completed probably, your DPT curriculum now covers all the medical screening, imaging, pharm, that good stuff. But especially if you're doing a residency or fellowship, you're taking a deep dive into, all right, what is my hypothesis generation? And you can eliminate it a lot quicker. It's just, streamlines your focus to become laser focused. And one case, I think I've mentioned this on someone else's podcast, it's like beating a dead horse, but this one really sticks out. It was a female, mid-40s, came in, looked like MSK, low back mechanical back pain, and I couldn't even get her to stand up. She was screaming. I tried very simple sagittal plane movements, flexion extension. No, I need to lay down. So I'm like, this is something that's going on here.
Yeah.
So tagged in the medical team, the nurse, the PA, the doctor even. And I said, this person needs to be worked up. I suggest maybe a CT scan, or, I don't think an x-ray is going to show much, but that's up to you guys. Like, this is not a MSK back case. So long story short, it mimicked, or it was an ovarian cyst that had burst, and it was presenting like widespread MSK back pain. So this individual got imaging, went straight to surgery, and now I think she's doing fine.
I love that. And I think that's one of the big reasons why we have PTs in the emergency department, right? Is because we are the musculoskeletal experts. So if we can't rule it into the musculoskeletal system, that's a big red flag, right? Like, if I tell you, like, I know this is in my scope, I know this is not in my scope. So it's really important for, I think, the medical team to know that when we're sure it's not MSK, we're pretty sure it's not MSK.
Yeah.
Because we've seen lots of that in a deep perspective. We've watched it recover. We know what it's supposed to look like. When you see enough normal, I feel like the abnormal really starts to show itself a little bit more clearly.
100% agree with that.
So one of the things that you said is assess, don't guess. And I like that. So tell me a little bit more about your process for that.
Yeah, first and foremost, kind of like, I like to go off the clinical practice guidelines by the ortho section. So again, number one, rule out red flags. And in the ED, especially urgent care or even acute care, ICU, whatever, I like to say medical comes before mechanical. So make sure that this person isn't going to die in front of you. And then, there's a good, probably 80% chance that it is just MSK, and you just need to talk the fear out of them and give them maybe one or two simple moves to maybe try and go from there.
Yeah. And I think once you find that first thing that gives them that little feeling of success, that little taste of success, that fear really decreases a lot. But I talk to people a lot about, like, hey, like, we got to calm the patient down before we do anything to them or ask for anything from them. So what tips do you have for people who are starting in the ED, or maybe working with difficult patients in not difficult patients, but patients in difficult circumstances, about how to do that effectively?
Yeah, for sure. That what you were saying there kind of reminds me of Greg Lehman. He likes to say, build shit up, or calm shit down, then build shit back up. Right. Sorry, Greg, if I butchered that. But yeah, I would, it's not for everyone. If you like more of a low key rehab, one patient an hour, you're trying to get good at your basic handling skills, the ED is not for you.
No,
if you're kind of an adrenaline junkie and you get bored easy, like we do, and you're like, oh God, another plantar fasciitis. Let me just tape them and send them. If you want to use, top of scope, if you want to do that, I would say give it a try. And I would love to see PTs now, and I think this is emerging, but have at least one PT in a primary care office or urgent care center. And same thing, we can easily, triage those folks. And then this person, based on the Ottawa ankle rules, I think has an ankle fracture. You go over here. Who's next? I feel like we're such a crucial part to that collaborative team. Yeah.
And I think that the more of that we do, the more upstream we get with that, the more downstream health savings we're going to have. And I think that's a hard thing to prove, though, unless you can get those pilot programs set up really nicely, because it's hard to show something didn't happen. Like, this person didn't stay in the ED longer because of me. This person didn't need imaging because they saw a physical therapist. So those things are a little bit harder to show, but the research does indicate that physical therapists can improve throughput time and decrease unnecessary imaging, as well as unnecessary opioid prescriptions. Is that kind of what you've seen in your practice?
Absolutely. And this, I'm aging myself here. I sound like a dinosaur, but this was almost a decade ago when I was doing this. And I think I asked you, I'm like, what is the go-to standard operating procedure for back pain? Because then they were giving out opioids, and that made me really mad.
Yeah, when I first started in the ED, I have a case study that I still share with students, and I share it because it is a little outdated, right? So this particular patient came in, 65 years old, came in by ambulance for back pain, and this is kind of a made-up case, but it does represent the standard. And she was pending MRI and given morphine and was like a PT eval and treat. And my question was to the students and to the residents at that time was, why are we doing an MRI? To rule out cauda equina. Great. What in your assessment leads you to believe that this patient might have that? Oh, well, they don't have signs of that. Great. Right. So why are we going to do that? And I think that that mindset has changed. And then also giving somebody, well, really anybody morphine when it's not really strictly necessary is not great. And let alone doing it somebody who's an older adult who is very opioid naive can be really dangerous and increase fall risk and other things as well. So I use that case as an example for students to pick out what's wrong here. First of all, why did a patient have to come by ambulance? Like, that's question number one. Why couldn't she get herself there? Right? Because that would probably tell you a lot. Number two is, why is she getting morphine? Like, where was the clinical, what else was tried? Where was the clinical decision path there? And then why are we jumping straight to an MRI when there hasn't really been anything else? So in this case, types of cases, we're able to go in and say, hey, there aren't any signs of MRI. Can we take a run at this patient before we send them to MRI? Can we take a run at this patient before you give them pain medications so that we can see if physical therapy can make a big impact for them? And then sometimes the option is pain medications plus PT. Do they need pain medications so they can participate in PT?
I think that's valid. Yeah.
Yeah, and sometimes that's the case because what are we taught in PT school? Like, Steve, if you go to somebody's house and you're treating them and they're in 10 out of 10 pain and nothing you're doing is working, you might need to send that patient to the emergency department. But then I'm the one that's going to see them. So at that point, it might be beneficial for that patient to have pain medication in addition to PT so that we can give that patient the maximum benefit, as opposed to just sending them from a PT who is worried about how much pain they are to another PT who's just going to try it anyway. So I think that's where some barriers are as well.
Absolutely. I agree with all that for sure.
So one of the other things that you kind of alluded to in the emergency department is you have to like the fast pace, you have to be willing to see whatever. But I think another thing that is important is your attitude and how you manage yourself in the emergency department. So what are your thoughts on that?
Yeah, you have to be a little cocky, to be honest. And
Wait, are you calling me cocky?
No, I'm calling myself confident, not cocky. But yeah, I had everyone was on my team because they knew my grandpa and they knew my mom. So like, oh, Steve Goostree's here. Like, let's see what he's doing. And I think all you need is that one buy-in. And mine was that poor lady with the ovarian cyst burst. And I caught that. And then the doctor's like, all right, this dude knows what he's talking about. If there's any MSK coming through the door, send it. And I had my own office, Rebecca. This was sweet. It was a little room with a door that closed. It wasn't just a drape. And I had a gonian, I didn't use any, I used my hands and my brain. And there was a bed and a gate belt probably, but I would literally sit in there and I'd make a lap every 15 minutes, kind of just see what's going on. That's another thing. If you're terrified of blood and guts and, don't work in the ED. But none of that.
It was the purple feet.
Oh yeah. I've seen some of those, but yeah, if you like horror films, you could work in the ED, no problem. Yeah. But yeah, so then I had my own laptop and I would literally watch people check in, and then I became close with the folks at the front desk, and then I'd pop up there, and then they got to know me, and they'd be like, "Oh, Steve, we were hoping you'd run up here. Here's someone with neck pain. They can move their neck." I would even tell them what to look for based on some of the C-spine rules and all that good stuff. And then I would walk them back from the waiting room, which how often do you see that happen in the ED? Never. People come in scared and they have no idea what's going on. There's sounds, you name it. Yeah. So that was really awesome. And then I would do probably no more than a 15 to 30-minute assessment. And I never did any treatment. Again, I was more triage than anything. And then it was beautiful because across the street was the rehab hospital where I worked as a PTA. So I knew the front desk staff there. I knew some of the senior PTs. And I'd say, hey, this is a physical therapy problem. How much time do you have? I can walk you across the street literally now. So I would call the front desk on my cell phone. They'd be like, oh, yeah, Rebecca has an opening. She had a no-show. Sweet. Let's at least get this person in, do an eval, and then get them on the schedule. So it was like a built-in referral system. It was very nice.
And I think that's a really good example of like managing the zone, managing the patient. So when you're practicing in the emergency department, one of the best ways that you can keep that practice sustainable is by managing the zone. So just like you said, looking at that patient track board, looking for cases that could benefit from physical therapy, offering to help co-manage those patients, helping with that triage process, and then helping that facilitation to outpatient. Now, these days, I don't know that you're going to find anybody with any openings. That's one of my biggest complaints about outpatient physical therapy is the accessibility, because the wait might be 3 to 6 weeks. Whereas like if I wanted to see a chiropractor today, I probably could find 4 or 5 of them to go see. So right. I think, but that process of facilitating that referral is really important. So you bring up a lot of good points there. Managing your zone, knowing what to look for, triaging your patients, and getting them the follow-up that they need.
It was super cool too, because they had a courtesy van. So then let's say like that lady who was in a wheelchair and scared to move, I would like transfer her into the van. I would hop in the front seat with the driver and we would literally drive them to the outpatient. I would wheel them to Joe Smith, whoever PT was open. And then I'd say, all right, I just saw this person in the ED. They're stable. Do the best you can. Maybe don't do any manual today. Like give them one stretch to work on or some deep breathing, something to calm their nervous system. Yeah, exactly. Get some buy-in, let them know that you care. And then that was awesome. Probably, honestly, my 15-year career, that was my favorite role ever.
I love that. And that would probably never happen now. Like the liability associated with all of that and like just hop in the van. We're going to on the street. But
that was like a decade ago. So yeah, it probably wouldn't fly today.
But I think I'm not joking when I say you could set up a tent in the hospital parking lot that says low back pain, stop here first.
Absolutely. I would love that. That would be fun.
Streamline the amount of people that are coming in because the number of people that go to the emergency department just with back pain is so high. And the number of people who have no other options of where to go or might not be able to get in to see their PCP for 4 weeks, don't even know what a physical therapist is. There's so much opportunity there.
Absolutely. And I think, especially, since you're going through fellowship, I'm a fellow, just the OMPT's role as the MSK expert in the ED is top tier for sure. Even doing like repeated movements. So I would always try to do a la, the McKenzie Institute. I'm not trademarking it. That's your stuff, but it's like that built-in safety system where patient-generated forces, then overpressure, then mob, then manip if needed. And same with like clinical CPRs, not, like clinical prediction rules. I did manipulate folks in the ED still did my mechanical assessment, very low irritability, just scared, hurts to bend forward. All right, based on Tim Flynn, just like these 5 are president, I'm going to do 2 quick manips, have you stand up. Oh, my pain's cut in half and now I can touch my shin. Sweet, you're pain adaptive. This is awesome. You don't need drugs or surgery or imaging.
Yep. And I think, what would you say to people who just don't feel confident with their skills in that regard?
Yeah, then just get good at teaching people how to treat their own back, neck, etc. And yeah, start with mid-range movements. Don't go to end-range press-ups, stuff, just use your clinical reasoning.
And get them as close as you can. One of the things that you've talked to me about is like having like a stable of techniques, like your leafy green manipulations that you can use with people. What would you suggest that those would be?
Yeah, just there's a million names for all of them. The Chicago roll, I like that name because I live in Chicago. But yeah, just like even the sideline lumbopelvic manip, you don't have to be super specific. We're not that dogmatic anymore. Just get the person on their side. Start with a graded mobilization. I would do that. Grade 2s. How's this feeling? It's uncomfortable, but not worse. Is it going down your leg at all? No, it's actually, I feel it more in my back. Sweet. Grade 3. And then keep it simple, Steve, because my brain is going a million miles a minute, but start with that and then do it for however long until you feel a little bit of less tissue resistance, or the person says, hey, this is like a massage. This is awesome.
Right.
And say, sure, I'm massaging you right now, but even though I'm not. But and then you have them stand back up, do whatever their baseline was. Like, I can't bend forward. Now try to bend forward. It still hurts, but I think I went further. Like, that buy-in right there, that's huge.
I agree. And I think sometimes that hands-on builds confidence in movement. Well, I did it while you were moving me. Maybe I can try it on my own. So sometimes it's just like after a surgery with the arm or like a rotator cuff, right? Like, first we're going to start with passive, then we're going to go active assistive, then we're going to go active, then we're going to load. So I think that you can apply all those principles to one session sometimes in ED.
Absolutely. And I would always give them one thing to follow up with, whether it was a repeated movement or a simple pelvic tilt. I'd be like, all right, we just put your back into place. Again, air quotes on that, because I don't say that stuff. Right. But, now that you're moving better, let's reinforce that with this real simple pelvic tilt or knee rocking side to side. And then if you're interested, I can definitely set you up later this week with then I would even say, I work over there. I will do your assessment if you're comfortable with me. And then I would let them know. I say, hey, instead of the ED, I want to be in the clinic next week, stuff like that. So it was so cool.
Yeah. And there are different places that do that, where a PT might be in the ED a couple of days a week and then in the outpatient clinic a couple of days a week. And I know of that model in the urgent care system as well. So you might work in the urgent care on Monday, Wednesday, and then you see the patients from the urgent care Tuesday, Thursday in the clinic. And that seems to work well for patient continuity as well. And I think it helps with buy-in too, if you know you're going to see the same person. Because so many times a patient will say to me, well, will I see you there?
Right. Yep.
And even patients in the acute care hospital, you're like, yeah, you're going to go home. You're going to have home therapy. And they're like, oh, you'll be coming to my home? No.
Right. They trust you.
Right. But that continuity of care can be helpful for patients.
Absolutely.
So another issue that we have in the emergency department, right, is a lot of people have yellow flags, what we would call yellow flags. Can you speak to that a little bit?
Yeah, I think, I don't know, the world's a crazy place. And after the pandemic, I think we all have yellow flags to some extent. Honestly, I've never seen, in the last 2 startup jobs I've had, we did, depression and anxiety screening on everyone at the, P8, QH, whatever. And I've never seen so many 25-year-olds with hypertension and are either anxious or depressed or don't sleep. It's insane. So what I like to use, and I've been burned before, like, I'm like, oh, this is a strictly nociceptive patient. He sprained his ankle. He's going to get back to dunking a basketball in 3 months. But this dude wasn't getting better. And I like to use the yellow flag risk form that the Rehab Institute of Chicago has put out there. And now I give it to literally every patient, because someone might be good at lying, or they don't want to tell you something. But this one gentleman, super active, played college basketball. I couldn't get his ankle any better. So I gave him the yellow flag risk form, and the affective component, he scored off the charts. So then I took a different approach versus manipulation and exercise and balance. We talked about some other stuff. So super important to screen for yellow flags.
And I think some of that is like starting from that perspective in the ED, right? Because most people that are coming in the ED are scared, they're anxious, they're overwhelmed, they're in a lot of pain, they don't know what to do. A lot of our patients have socioeconomic challenges, who are also just sitting there totally panicked about the cost, and they're trying to choose between their health and the cost of their health. And I think that's it. I have had times where I've been asked to stop screening for it, because then we have to provide those resources, and and like, you're right, like almost everybody needs some. So I still do it because it's part of our duty to make sure that we're getting people the care that they need and providing them those resources. But
absolutely,
it's so prevalent that you might get that pushback. Well, everybody has this. We can't treat everybody's anxiety and depression. We can't fix everyone's social determinants of health right now. And I agree. But we do need to be aware of them, because we can't make a realistic discharge plan if we don't have the whole picture.
Absolutely. And another interesting, so I saw a lot of spine, obviously back pain, neck pain. I saw a lot of shoulder dislocations, because this hospital is right next to a big bike trail.
Mm.
So a lot of people would have a Fuchs injury. They would have an AC strain, or I've even, one of the ER docs knew I like big ortho guy. I saw him do probably a dozen, like, reduce a dislocated shoulder, and he let me try one. And that was one of the coolest things ever. As an AMP fellow, I was able to like do some bone setting. Super cool. But those people that are active, they don't really they have red flags. Their shoulders out of the socket right now. But
Right.
in terms of yellow flags, their endorphins are kicking in. They probably would have been a 10 out of 10, but they're like a 5 because, now they're in the ED. They want to get back out there tomorrow or yesterday and get back on their bike. So that type of folk, I wouldn't probably do a yellow flag risk for them because it seems almost purely nociceptive at that point.
Yeah, I get a lot of paratroopers.
Oh, wow, cool.
Because we're pretty close to one of the military bases here. And so I see a lot of paratroopers with dislocated shoulders or pelvic fractures, things like that, little ankle issues. Whenever I talk to a paratrooper, they're always like, it's always the last jump for a reason. It's never usually by choice. Yeah. But I would say, kind of just to your point, one of the hardest afternoons I had was when the guard was drilling in our community, and they had multiple branches of the military all there doing drilling. They had changed the protocols. They had this crazy drill, and they dropped off a busload of soldiers in the afternoon. Okay. Just an entire bus full of people with minor musculoskeletal issues, ranging from dislocations, burns, lacerations, low back pain, neck pain, like all kinds of things. And in come 8 soldiers that all need PT at the exact same time. That was wild. But you would be surprised how many of them still had yellow flags that really needed to be screened for, even though they were like active duty, doing everything they needed. Their healthcare was taken care of. So just always making sure you're at least asking those questions to make sure your patients are okay and in that space before you get started, even when it's one of those days where you can't catch your breath because you got a whole busload of patients in the waiting room.
Yeah, and how easy is it to have them call, well, not in the trenches, but even virtually, I've had people, I always like to ask the 2 pressing questions, right? And this can be uncomfortable, but we're doctors of physical therapy. Like, are you in crisis right now? Are you going to harm yourself or harm others? And yes. I've had a dozen people hang up and call 988 and then say, send me an email after you make that phone call and let me know how you're doing within the next 24 hours, please. Like that's crucial.
Well, and I think too, if that's where they're at and they're in the ED, they're in the right place. And there are people in my ED, at least, who have the same job as me. Their job is to make sure somebody is safe to go home, but from a mental health perspective. And I always think, gosh, that job would be so hard. I don't know how I would ever do that. And they're like, well, your job's hard. I don't know how you ever tell if somebody's going to fall down the stairs or not. It's like we're both trying to predict the future based on our exam. And so
we're basically life coaches. Yeah, we're life coaches as well as PTs.
And sometimes you have to partner to make those decisions or make those referrals. And I think that's a big part of what we do because patients want to talk to us.
Absolutely. And we have the time usually to be able to chat a little bit longer versus the doc that's in and out in 30 seconds,
We've got the time, that therapeutic alliance. I also find if people are willing to let you put your hands on them, they're usually more willing to communicate with you.
Absolutely. That's a good point.
And you have to bridge that trust gap somewhere to be able to even get to that point. So I think that's really helpful. Right. So tell me a little bit about what you think the future of AMP fellows are, manual therapists. Where should they be practicing?
Anywhere. Anywhere that a PT can practice. Even, I don't know, I don't like the label, like, oh, I'm an OCS, you're an NCS, correct? Like, good for you. I want more NCSs to be AMP fellows. And I don't know about peds. I don't believe in manipulating children, but even, just go through the program, work on your clinical reasoning, your pain skills, your soft skills, stuff like that. I'm very passionate about the ED, obviously. That's why we're here, right, chatting? But urgent care, have us be more, even in like pro sports. It's always the ATC that runs out there. I want to see an AMP fellow on every sideline, every major sporting event. It's a lofty goal, but that would be awesome.
Yeah, and I think when I talk about top of scope practice, I really mean like we need to stop thinking about physical therapy as a location, a place where we provide an intervention, and more of a management mindset. And we go to where the patients are because we're solving society's problems, we're solving patients' problems, and we're going to where those problems are. We're not expecting those problems to come to us. So, in my mind, for people who are consider themselves to be manual therapy specialists, if you're only working in the outpatient clinic, you're missing out on so many people who could really benefit from your services. When I worked in brain and spinal cord injury rehab, we literally brought in an outpatient manual therapist like one time a week to help treat some of the other deficits in addition to the neurologic and the functional, because it all works better together. So if you're a new fellow or you're thinking about an orthopedic residency, or you're like, gosh, I'm an orthotherapist, I'd never work in acute care, we want you to rethink that a little.
Absolutely. And I used to be scared when I worked at the Shirley Ryan Ability Lab. I'm like, I would look at my, 8 to 10 patients that day. All right, sweet, ortho, neuro, and I would freak out. But then my mentors would be like, Steve, you know what you're doing. Everyone has a brain. Everyone's neuro, everyone's ortho. It's all mixed. Yeah. So
we shouldn't have specialists. Like I personally really want to be an all patient therapist. I want to be able to at least evaluate anybody and anything one time and know where to send that person competently. I want to be a specialist at being a generalist. But
me too. I like that. Yeah.
there should be specialists, right? Like I just had a Liz Frank fusion. You better believe I'm seeing somebody who specializes in foot and ankle, not somebody who's never done that surgery before. So I think there's a time and place for all of us to coexist, but we need more people with huge skill sets getting into unexpected places, doing unexpected things.
Right. I think residency and fellowship should almost be required, down the road. And yeah, you can specialize, but then you can subspecialize. And orthopedic manual PT is not the only thing you can do a fellowship in, right? You can do D1 sports. You can do spine out at USC has an awesome program. You know what I mean? Like women's, or not even just women, just pelvic health in general. Find your subspecialty and work anywhere.
There's so much opportunity. We just need to find it and build it. And I tell PT students sometimes, your career might not exist yet. Your profession exists and you're joining our profession, but your career might need to be built by you. And I love that, like the excitement of that.
Oh, me too. And that's the thing. We're like just getting the ball rolling. I feel like
starting.
PTs were definitely behind, obviously, physicians and nurses, but all these little wins, like, oh, now I can order imaging, stuff like that. Like we're primary care providers. We need to start acting like that and not techs that do ultrasound and massage and heat. And, that's silly.
So what are your parting thoughts for people listening to this episode? How are you going to sum it up and leave people with something to go home with?
Yeah, I guess be bold, top of scope. Don't be afraid to learn cervical, thoracic manips and give it that green leafy vegetable to the CT junction. Don't be afraid to dry needle someone, obviously with the proper training. Don't be afraid to work in the ED and say, hey, I think this person may need X, Y, and Z. That's where you guys come in. This is just my PT professional opinion. Don't be afraid to screen for yellow flags, anxiety, depression. Everybody has something now because the world is nuts. So just have an open mind and obviously do residency and fellowship training and you'll be confident, not cocky.
Well, thank you so much for being on the show. You've been in the ED now and you're officially discharged.
Sweet. Thanks, Rebecca.